It's a real pleasure to be here and to see so many familiar faces, and it's a pleasure to have a chance to hear Pam and Ken share the opening remarks and hear so many of the thoughts echoed over and over that we've been working on for many years. I'm always awed to be in these rooms with the individuals that are here today. I still feel like I'm very new to the conversation, even though it's been a few years now, because this has been a journey that's been underway for a long time. We've been working towards what it means to use technology to deliver health care. And it sounds like our military experience has shaped much of what we do today in many ways. Part of my military experience was having a paper record, but having electronic labs, electronic pharmacy, electronic consults. And so the power that when somebody walked in the room and they didn't have that paper chart, I could still figure out about 2/3 of their history based on their labs and their pharmacy. And that was very, very powerful. And then I got to do some moonlighting in an acute care clinic that was strictly electronic. The only piece of paper was the prescription that got printed. And so going from a government environment to a private payer environment and having the decision support that said, if you do this code, this 99204 thing, you better have documented A, B, C, D, and E was really helpful because I really didn't want to commit fraud. So those experiences, though, are such that even though I've become a more bureaucratic administrative type provider, it shapes the feeling that I wouldn't, if I were doing clinical work, I wouldn't want to do it without an electronic record. And one of the things that we're seeing now is there's so many folks that are going through training, and especially as our universities and medical schools are adopting electronic health records, providers coming out of training, there are folks that have never used a paper record. So it really changes the way we practice, and it's the business change in how we practice that's so transformative. So the title of this is using data to improve healthcare. And I'll admit I didn't come up with a title, but as I was thinking about this, and one of the first thoughts though around it was the fact that it talks about improving healthcare. And so I've just recently changed roles, and when I agreed to do this talk, I was actually in the old role. So it's been an interesting transition, but as Libby mentioned, I was at the Department of Public Health, and part of that role was around being the state registrar and working with eHealth and the adoption of public health or a meaningful use in HIE and how that would relate to public health. And I had that chance to serve as the interim deputy secretary, and being able to pick it up where Jonah left off. It was an entirely different job then, and now to be able to turn it over to Pam was a very happy day. I was so thrilled that she agreed to take on this adventure and to bring the skills that she has to this role, because it has changed. We have each, at the different times of the deputy secretary role, it's been a different world. A year makes a huge difference. And so in that context, I had the opportunity this spring to apply for a new position at the Department of Healthcare Services, which is where Medi-Cal is situated, as well as a number of other programs. And it's the role as a Chief Medical Information Officer. So in that role, I'm getting to report to the medical director, Dr. Neil Kahatsu, and part of that is to try to dive into this area that around data use and data governance, and how do we use the data to then improve care and to evaluate care, and what is it that we're doing, and how are all these different touch points and interfaces going to happen. So in some ways the title of this talk matched the job that I didn't know I was going to have. So it's been very exciting. One piece, though, that struck me about it, improving health care. And health care, often you hear that and you think of the delivery system. And one of the things I think has been a real theme over the last few years is and Dr. Kaiser mentioned this, is there's the delivery system, the delivery of health care, and then there's everything else that really influences how healthy we are. And as a provider, I felt that. I get to see somebody for 10, 15 minutes, and that's a long visit. And yet there's everything else that happens that affects somebody's health. And how do these two pieces start to come together? And this is where I think HIE really serves almost a magical potential to connect those. Because the healthcare system, which is very expensive, We all have heard the conversation around cost out of control and the quality issues. But how does that link into what happens and really shapes our health, which is outside of the doctor's office? And how do we combine those and also then provide the provider, the physician, the nurse, the medical assistant, et cetera, give that provider the tools so that they can get their patient connected to all these other services and components that affect health. And so HIE has a real role to play, and the fact that technology has advanced so much gives us a chance to have a very different conversation than 2 years ago, 5 years ago, 10 years ago, that Dr. Kaiser mentioned. So he actually referenced a number of these areas. There are a number of quality initiatives underway, stemming from both the federal side and then also being endorsed and stewarded at the state side. And just to get kind of a read, how many people know about the Coordinated Care Initiative? Delivery system reform, incentive pool type stuff. So I didn't put slides in here, but I do want to really urge you to look these things up. Dr. Kaiser mentioned them, I'm mentioning them. These are the business drivers for health information exchange. These are the things that are taking a look, so especially the Coordinated Care Initiative. It got passed in the budget. 8 counties will be doing this, and no, I don't have them memorized, so please don't ask me. But it's available on the Department of Healthcare Services website. The key thing here is looking at our dual eligibles, Medicare, Medicaid, and how do we coordinate care? And how do we coordinate care not just about the visit to the doctor's office, but then the specialty care, the long-term care, the community services, the social supports that keep them out of the hospital? How do we do that? That coordination of care is dependent on HIE if it's going to work. So these are the business drivers that really are moving us forward, and it's about having the data at the right time that Pam mentioned. So we're seeing the initiatives coming from CMS, AHRQ, CURSO, CDC, et cetera. So there's a number of these different things going on. Also in California with our 1115 waiver for Medi-Cal, there are a number of components there that are also looking at, again, how do we pay for care? And let's pay for it based on the quality and about the outcome and not necessarily each physical interaction with the patient. And so again, in order to do that, you then have to start looking at populations. The provider's population, the clinic's population, the hospital's population, the health plan's population, and then compare that against others. So there's a lot going on that we really need EHRs and HIE to help with. And so just because I can't help it, I have to infuse a little bit of public health. Really, health is tied to place, and we see that over and over again, and our data has shown that. But how do we then take that and then, again, use it to help connect? So these are just a few maps from our public website, but this is Sacramento County, if you don't recognize it. But what I did is I just pulled a couple different looks, and it highlights, in this case, the darker the red, the more there is of it. But looking at percent of births with late entry into prenatal care, percent of births with Medi-Cal as the primary payer, percent of births with, to mothers with no high school degree, and infant mortality rate. And what's not surprising is that many of the same zip codes are similar colors. And that's part of that. Health is tied to place. And yet that's often where the healthcare delivery is the least robust. So it really provides a need to interface, because people don't just stay, though, in one zip code. They may live in one place and they work in another, and they travel, and then they end up in different places. So how we understand the community, right now, when we try to do this, we use things like vital records, reporting registries, telephone surveys, in order to know how happy are people with their provider, or how fast do they get into care. We were trying to find that number as a quality measure to support the national quality strategy, and the only data we have is behavioral health surveys, where they pick up the phone and they call people and they say, how long did it take you to see the doc? That's it. Well, wouldn't it be great in a system where we had electronic health records and HIE that we could actually start to measure that from date of primary care visit to date of specialty visit by diagnosis? Then we can start to really address the challenge, not just essentially the symptom. So in the future, what kinds of data will we have? EHRs are changing this. Maybe we'll have ambulatory as well as hospital discharge data. Patient-managed data and health histories. This is another one. How many times do you walk in the doctor's office and you get the piece of paper, fill out your social history, family history, et cetera? What if you could carry it around on your smartphone and just say, okay, here, read the barcode, now you got it. The patient may be responsible for carrying their health information. And community services, again, how that interacts, and this is where HIE really has a role to play. So when high-tech came along and put things like the ONC into statute and said a key role here is how we look at the population, the public health, and outcomes, and we're going to address those things that are high frequency, it was really exciting to see. It really, I think, helped start to lay that foundation. We know that it really laid the groundwork for the Affordable Care Act. So again, you all are folks that are very familiar with this, but high-tech era, not Affordable Care Act. And then there's all these other initiatives, though, that come with the Affordable Care Act, accountable care organizations, the dual eligibles, that are dependent on high-tech and what we're doing and the work that you're doing. So it really is transforming the way we work. Pam mentioned she tends to stay at the policy level as opposed to the techno level. One of the things, though, we do get so involved in the details, and like there's the meaningful use measures, and you got to get 25 of them, and these are the stage 1, and these are the menu, and these are the core. But ultimately, what the meaningful use measures are about is trying to have an electronic health record that helps us do these 5 things. And so I do like to try to emphasize this because, again, it helps us stay a little bit focused on why we're working on this. So improving quality, safety, efficiency, and reducing health disparity. Engage patients and families in their health care. Improve care coordination, improve population and public health, and as a invaluable base, ensure adequate privacy and security protections for personal health information. Because without that, it all kind of comes to a stop, and we've seen that happen in the past as well. So we're in a re-engineering process, and many of us have been through the whole going from paper to automation. It is a process. There's the first round. You get some of it. There's the second round. Then you realize, oh, now that it's electronic, I don't have to actually move the paper. I could just push the button. You know, there's a lot of transition that happens that's well beyond the technology. And so we're doing that. All of the different programs, the high-tech and others that are partnering with us, private and public funding that are coming to make this transition happen. And so because I think this piece is so exciting, I have to show the map. Again, I also kind of got into public health through GIS and Dr. Hogarth, who's around here, and to dive into this. So I love looking at the maps. This was in November 2011, how many EHR incentive payments had gone out across the country. And just to highlight, in order to be dark green like Texas, you had to have given out more than $75 million. Okay, so that's the scale. 7 short months later, we have over $5.5 billion that's gone out. Over 100,000 providers have received, and that's hospital and individual providers have received payments. And now to hit dark green, you have to have given out 150 million. So the scale's doubled. There's a lot more states that have hit dark green. So those that have given out 150 million are these states. Texas is still ahead of us. Gosh darn it. We're catching up, though. They've given out 539 million, and again, this is data as of May that CMS has. Okay, we've actually given out more than this. It just takes time for it to process on their website. But of the 413 million that has gone out, essentially half of it's Medi-Cal, Medicaid, and half of it is Medicare. So that's tremendous. There's over 4,000 providers, Medicare providers, that have received payments, and that means they're doing meaningful use, and that means they have to really start trying to figure out how to use structured data, because they're doing that for meaningful use. Medi-Cal, they just had to get the contract, so they're not quite as far along. We have a huge number of providers. I don't actually have the number memorized right now. It's probably, what, 6,000 or 7,000, I think, that are in the queue. That we're working on getting payments out to, but we've already paid several thousand, which, you know, just as comparison, the whole, if you fold the map and California is here and then you have 11 states on the other side, I mean, we've paid as many providers as most other states, and there's even 7 states that haven't paid any because they don't have a Medicaid program up and running yet. So we are doing really well. Yes, we have a lot to go, and yes, we know providers are anxious to get payments. But when we step back and look at the bigger picture, we have really done tremendous. And those providers that have adopted EHRs, especially the 4,000 Medicare providers, they are looking for HIE connectivity because they know stage 2 is coming and they know that they need to get going there. And plus, there's this other thing that happens once you have an EHR. Now, instead of dropping to paper, printing it out, putting it in the fax machine and sending it to somebody, you want to connect. because it seems ridiculous to have it electronically and then turn it into a PDF that you then move somewhere else to then have somebody else type it, right, into their system. So this really is creating the demand and moving things forward. And as both Pam and Dr. Kaiser mentioned, the enterprise or private HIEs, they're solving a business need, especially around administrative data. And this is another thing, again, when we look at those quality initiatives, the dual eligibles and the delivery system reform, it's not just clinical data, it's also that administrative data, and how do we move that more effectively? And so there's a business need that is being met with HIE, and how do we then expand that to the community? How do we deal with the public reporting pieces, and not just public health, but other public reporting, quality measures, et cetera, that we have that need for? So we've mentioned this before, again, structure data so that you can actually look at the patient population. How many of your diabetics have had their hemoglobin A1C tested in the last 6 months? It's one of those things that if you track that, you keep it at a certain level, U.S. Preventive Services Task Force says that you will have improved outcomes. So we have measures that we can tie to outcomes that have evidence behind them. And so this is our chance to start really looking at it. And we are. And so there's folks like the Office of the Patient Advocate. Has anybody been to their website, Office of the Patient Advocate, California? Okay, I urge you to go look it up, because one of the things they do is comparing plans and looking at quality. And they have now moved into the California Health and Human Service Agency effective July 1st. And we're going to be partnering with them in terms of how we look at how folks are doing. How do they compare? And that's within California. And data, of course, is essential for that. So extending the norm change, EHRs, and this really is a norm change, actually using the technology to then deliver care. It starts with that EHR adoption, but it goes further. And that's really where we're seeing the focus now, looking at the accountable care organizations, the dual eligible pilots, the delivery system reform. These things are also tied into the National Quality Strategy and the National Prevention Strategy. And so just out of curiosity, and I appreciate you all participating in this involuntary survey, or voluntary survey, it's voluntary. I didn't force you to do anything. Yeah, sorry, it's still early. I was on vacation yesterday. National Quality Strategy, has anybody read it? Prevention Strategy. Okay, I'm going to give you the key points, but again, I do encourage you to take a look at it because it is driving governmental policy, and thus it is driving where we are going to put dollars. The National Quality Strategy. It was actually at our ONC site visit a year ago. Is that just a year ago? A year ago. Chris Muir from Claudia's office came out, and he said, and every single group that he met with, he said, National Quality Strategy, it was published in May, you need to know about it. It's about better care, healthy people, healthy communities, and affordable care. Pay attention. It's going to show up in your measures some way, somehow, don't know yet how. Take a look at it. Well, they've now published the update as of this last May. It's now zeroing in. There's actually 14 measures that are called out in the National Quality Strategy, plus a number of priority areas. And we're looking at that here in California in relationship to our Let's Get Healthy California Task Force that the Secretary is leading, Secretary Dooley. And we're also looking at the National Prevention Strategy. So we're paying attention, and we are aligning, because we know that this is where both federal funding is going, and also this is work that's been done. There's been really leaders in the field have come together to help lay these out. And there's links here. National Prevention Strategy has a foundation for prevention efforts, again, health and safety communities, clinical and community preventive services, empowered people, elimination of health disparities. Sounds a lot like the CMS priorities for meaningful use. There's a lot of similarities here. So we're seeing it again and again. And of course, it echoes what we see in the triple aim. And I can tell you on the government side, we're hearing triple aim a lot. So again, improve patient care experience, improve health of the population, and reduce the cost. So how we do that. So California, with our Health and Human Service Agency, I mean, we really are so thrilled to have Pam there, and Scott Chrisman as her assistant director. There's a lot we need to do to transform the way we do government work around an EHR world. And so we're thinking about how we do that and starting to plan for that. She mentioned the use cases, looking at foster care, stroke, and earthquakes. We know those are big ticket items. So understanding, though, these dependencies, how does what's happening in the community impact the health so that when somebody comes in to see the provider, you have that context? What are the things that would be helpful for the provider to know about the community? People who work in the ER, school attendants, they know when there's a flu outbreak, right? You know, it's all coming through the door. But there's other things that are not necessarily quite as common or that are maybe a little more subtle or take longer to show up. And things like diabetes and obesity are also epidemics that take longer. And we see it being more in certain communities. So how do we help get those people connected? Because you can't give somebody a prescription for their to go exercise, and if they then go home and they're worried about getting shot if they leave the house, they're not going to necessarily go out and exercise. So how do we help them get means to do that? So transitions happen though. So whether it's being at the transition from home to the doctor's office to a hospital, to a clinical care setting, to a long-term care setting, to a community home, transitions happen, and that's where, again, where HIE really plays a really key role. So data is essential to improving healthcare, because we're really about doing it in focused and measurable ways, and that's where the partnership with Dr. Kaiser and the Institute for Population Health Improvement is really important. We're looking at the evaluation. How are we going to evaluate to show that something did make a difference? So just as a kind of high-level recap, in the last century, the big successes, according to CDC, the Centers for Disease Control and Prevention, vaccination, that ties to healthcare, motor vehicle safety, safer workplaces, control of infectious diseases, decline in deaths from coronary heart disease and stroke, safer and healthier foods, healthier moms and babies, family planning, fluoridation of drinking water, and recognition of tobacco use as a health hazard. So my challenge, though, is what are going to be the 10 accomplishments for this century? And I'm sure that adoption of technology in healthcare and the implications for then the way healthcare is delivered is going to be in this list somehow. So evidence-based decisions, quality improvement, making quality improvement the norm to be expected, not just in an isolated way. Prevention to address the determinants of health, again, linking outside the doctor's office to inside the doctor's office, looking at the disparities, decreasing cost of care. We know we've got to address that. So that's sort of the question I wanted to leave you with is what will be our top 10 for this next century, and how will the work that we're doing around HIE, HIT, EHRs, and the whole acronym alphabet really help transform that. And so again, when we're talking with folks outside of the converted here, making it real, looking at these quality initiatives, looking at the different kinds of things in the prevention strategy, the quality strategy, those are the things they're focused on around how do we transform this system to improve care, decrease cost, improve the health of the population. So making sure that as we talk about technology, we keep it in that realm will really help, I think, engage the broader group. So with that, I'll finish. There's a few links I'm sure you're all really familiar with, but I really appreciate the chance to talk with you today. And we'll get to be here, I think, through the mid-afternoon, and I'm pleased to have this opportunity. And looking forward to working with you in this new role that I'm stepping into as I learn from a whole new fire hose, learning about health plans and all that stuff. I'm learning a new set of acronyms. So thank you very much, and look forward to talking to you more.